Thank you for joining us today. My name is Joy Tewksbury-Paps, and I'd like to welcome you all to today's webinar, Tactics to Improve Dialogue Between Medical Coders and Auditors, which is being sponsored by MDaudit. For those of you who do not know, MDaudit is a leading healthcare billing compliance and revenue integrity platform that partners with the nation's premier healthcare systems to reduce compliance risk, improve efficiency, retain revenue, and enhance communication between cross-functional teams through sophisticated analytics and AI. We're excited you could join us today for this popular topic. I can assure you that you will walk away from today's event with insights for billing compliance, HIM coding, and revenue integrity teams. Before I hand the presentation over to the expert, there's a few housekeeping items I want to go over. Today's event will be recorded. All attendees will receive a copy of the webinar recording, the slide presentation, and the CEU certificate in your email within the next few days. There will be a dedicated Q&A session following the educational portion. Feel free to submit any questions you have throughout the presentation through the Q&A portion of the Zoom panel, and we'll do our best to get to as many as possible. If we don't get to your question, we will reach out to you after the webinar concludes. At the end of the webinar, you'll be presented with a very short survey. Please take the time to fill this out. You have the opportunity to submit topics for future events and request follow-up from an MDaudit representative. We invite everyone to stay online after the Q&A session for a short overview of the MDaudit platform and how our solution can help your teams achieve the success being discussed today. Today, you will be hearing from MDaudit's Director of Market Strategy, Dana Finnegan. Dana is a seasoned expert with over 2 decades of experience in the healthcare revenue cycle continuum. Dana has been an invaluable member of the MDaudit team for over 6 years, currently serving as the Director of Market Strategy. With a wealth of expertise spanning professional billing, hospital billing, payer and vendor spaces, Dana has honed its skills through various roles at Mass General Brigham, a prominent AMC in Boston, Massachusetts, as a subject matter expert in billing, coding, and revenue generation best practices. Dana brings unparalleled insights to the table. With that, it gives me great pleasure to pass this over to Dana.
Okay, great. Thank you very much, Joy, for the introduction and the housekeeping. Folks, we are going to take you through. We're going to quickly go through the agenda. At the end of the day, what we're really here to talk about is really how to learn and how to foster and improve communications between auditors and coders. So it's not just the communication part, but what are some of the best practices and processes that can be put in place so these two different stakeholders can always have a healthy dialogue and collaboration. We're also going to dive into some statistics of how coding just in general can really truly affect revenue margins. Getting it right is so critical to healthy bottom lines. And then we'll also talk about how those auditors and coders and technology can all partner to really ensure billing is submitted with the highest levels of accuracy and integrity. And really the fourth piece is education. Education is key, so these risk factors in coding inaccuracies can be mitigated going forward. Really, before we get into the statistics, I just want to mention that what we've found in our MDaudit community is that the dialogue and process between auditors and coders is incredibly important, as I said, to achieve positive margins, but not always so simple to operationalize. So even within our MDaudit community, where coders and auditors are brought together to have these type of healthy dialogues, things don't always go so smoothly. So we're going to talk a little bit first about some statistics that all of us should be aware of. Now, these statistics come from what we have seen in our data within our community, and we want to present these to you because I would like you to go home with some really key nuggets that you could dive into your data and see if you're having some of the same issues and really how to unearth those. So statistics aren't meant to bring us down. They're more meant to make us aware of what's really going on out there. So let's talk about that. And then once we talk about some of the statistics, we'll get into the actual best practices between auditors and coders, et cetera. So I think the first place we want to start off is, again, despite a lot of noise in the market around autonomous coding and CAC and AI and all of these kind of terms that we're hearing, it's great because it gets coding and coding professionals the help that they need. They have an incredibly hard job. But with all of that, coding still remains one of the biggest revenue realization opportunities in our health systems. There's still a lot of leakage there that we could stop. And what we found in our data in 2023 was that on the more than 10% of professional claims, 3% of outpatient claims, and 3% of inpatient claims were initially denied specific to coding related issues. Now, to be more specific, that's taking out things like authorizations and pre-certs and credentialing and things like that. This is that 17 billion that I'm referencing from our community, and a 16% of overall denials, again, just very specifically to things like medical necessity and clinical payer policy and things like that that were very specific to coding. So still really out there biting our margins. And just as you see down at the bottom here is initial denied amount on the pro fee side over $300, outpatient $740, and you can see that whopping number on the inpatient side of almost $8,000. So we still want to be, we're fighting a lot of different denials in the front, middle, and back of the revenue cycle continuum, but that middle section where coders and auditors are working together is a section that we really want to hit hard and put in some best practices to stop some of this revenue leakage. This here, I want to first start off by, I really struggled with the title of this slide because it says, more than 50% of coders failed audits. Again, I've said this before, coders have an incredibly hard job, coupled with the fact that payer policies is constantly changing. It's hard to keep up with. It's hard to find really good coders. So I want to put out there that you guys have a really, really tough job, but I do want to dive into the stats that we've seen. So we did see when we took the inpatient, outpatient, and pro fee side that more than 50% of coders didn't pass their audits. And on the pro fee side is what you're looking at right now. And this is one of the nuggets I want to kind of send you home with. These coding denial reasons on the pro fee side, these come straight from claim adjustment reason codes, the CARCs. You're all familiar with those, of why things denied for those coding related reasons. And you can see really the highest dollar amount here is payer deems the information submitted does not support this level of service on the pro fee side and some of those other reasons. Going to let you take a look at those before we go on to the outpatient side, and then we're going to find out what the common thread is. So payer deems the information submitted does not support this level of service, really big one on the pro fee side. If I move to the outpatient side, you'll see here, again, the biggest dollar amount of almost the 1986, almost $2,000, again, is payer deems the information submitted does not support this level of service. So I want you to take down that CARC code, that claim adjustment reason code is denial code 150. It's a really good one to go into and then drill down to, what payer is telling me this, that the level of service isn't reported. And kind of more importantly, try to track that back to the coders that are coding those services. It really helps you not only understand the payer policy, but who is coding for those services in your coder population. Again, some of you know this, but the most recent, when we dived into the data, causes for this was insufficient documentation, meaning claim went out, payer requested the documentation was sent to the payer, and they kind of looked at the claim you submitted, and the documentation said, they said wouldn't have coded it this way. Either it was up-coded, it was down-coded, many different reasons, or the documentation that was submitted just literally didn't have that level of medical necessity the payer is looking for. Again, inaccurate coding, lack of medical necessity, upcoding. Sometimes it was just that they were non-covered services. Services that the payer said, we don't cover it in our policy. So again, on the pro fee side, in the outpatient side, please look at that CARC 150 and drill down to a lot of those attributes that you'll need to be aware of. The payer, is it a non-covered service? Was it a medical necessity denial? You can find a lot of low-hanging fruit there. And again, always track that back to your coders that are coding for those services. On the inpatient side, this one was very interesting. So these diagnoses are not covered. You can see that $27,000. And again, this is average. It could be a lot higher in many cases. Diagnoses not covered. We saw a lot of instances where payer policy was very clearly stating the diagnoses that they did not cover, that were being sent out on these claims. Now, doesn't mean that you're just going to have your coders put on something that's not covered or not supported in the documentation, but it's very important for coders not only to be able to code for these services based on the documentation, but that coders are exposed and understand payer policy as well. We're going to talk about in a few moments how coders can really be deployed, not only to code whether it's inpatient services, outpatient services, pro fee services, but also be put on special units to be coding for very specific payers, because then they'll understand what those payers need for diagnoses, what the payer policies are, what documentation is needed, and brings a lot of expertise. So a lot of this gets mitigated. But where we really wanted to go, and you'll be getting this deck, is these are some of the really high impact, high dollar claim adjustment reason codes, CARCs, that you're going to want to look at your own data and do some drilling down to root cause. So takeaway here, folks, is certainly not an easy job to be coding these claims with payer policy and regulation constantly changing, but it is such a huge source of lost revenue. Where I want to go now is average dollars per initially denied claims. So a lot of our folks came to us and said, my denial rate, my first pass pay rate is getting better. My denial rate is going down on initial denials, but it was only this almost a negligible percent it was going down. And that's good. But what we saw was the average dollars per initially denied claim actually went up. So on the pro fee side, you can see a 15% increase, outpatient a 3% increase, and inpatient a 4% increase. So, pro fee, very, very big swing there. Inpatient 4% when you're thinking about the dollars that are submitted and the cost to take care of those patients, that 4% increase can be crippling. So just an FYI, don't just sit there and say, well, my denial rate went down a little bit, so I'm in a better place. We're seeing that it's almost standing in the same place when you consider the initial dollars per denial have gone up. So that's another KPI you want to put right next to days in accounts receivable and first pass pay rates is did the dollar per denial go up? And my gut tells me it absolutely did. And this first statistic is for both governmental and commercial payers. Now, we're going to take a jump into just commercial payers because we found them to be quite a scourge when it came to margins, really doubling down on denials from the commercial payer perspective. So one of the statistics that was staggering when we dove into the data was 31% and 38% of claims were initially denied by commercial payers on both the inpatient and outpatient side of the fence. Pro fee still went up 20%. But when you look at 31% of inpatient claims from commercial payers being denied initially, again, those are the claims, very high dollar, very acute patients. To get a denial on that and then have to rework it and then not get paid for several months later, that loss of revenue, again, I use the word crippling on the inpatient side. even more on the outpatient side at 38%. And as we all know, the service mix from inpatient to outpatient is happening. There's a lot more being done on the outpatient side. That's where the industry is going. Procedures at ASCs and things like that have gone from the only inpatient list to the outpatient side. So when you consider 38% being denied by commercial payers with that industry shift to the outpatient side, that is staggering as well. So again, statistics, you'll get this deck to go in and see, am I seeing the same trajectory in my initial denial rates? And I can tell you that if you compare your government to commercial, you're going to see the commercial mix is really doubling down. So that is just initial denial. This here is commercial payers on top of really doubling down on the initial denial rates. Is you can see here, their initial dollars per denial is also going through the roof. You can see on that bottom section of commercial payers, a 30% increase on the pro fee side, 2% increase on outpatient, and 5% increase in inpatient. So again, when you consider not only are they denying more initially, but the dollars per denial are going up, it's the perfect storm of challenge, particularly for the auditors and coders that have to fight these denials and these causes to shrinking margins. And again, we're filtering out in these statistics things like authorizations and pre-certs and credentialing and things like that. This is very specific to just coding. And the last statistic we want to really understand about commercial payers, again, is their response times. So we also found, and again, it's almost like the perfect storm of three, denying more initially, more denial dollars per denial, and then this piece, that it's taking them historically the longest ever to just respond to claims. I'm not even talking initial adjudication. So if you see at the bottom there, average lag days, another way of saying how long are they taking to respond. You can see on the pro fee side, 17 days, outpatient 29 and inpatient 35. So just to respond and then deny, taking 35 days. Think of quadruple that in terms of the time it will take you to analyze the denial, work it, send it to the right person. Is it a coder? Who is it? It's going to be several months before payment is received. So again, we're not here to try to paint a grim picture. It's just that sometimes we don't always understand, especially in 2023, 24 now, the doubling down of payer behavior. So we're going to move into a little bit of a different section here. This is documentation requests, and I'm going to give you some really interesting examples to talk about this and what we saw. So documentation requests specific to coding and medical necessity drove more than 45% of those initial denials. So you can see here on the pro fee side, that was 23% of the denial reasons. On the inpatient side, on the upper left, that information needed about 13%. And on the outpatient side, in the bottom right, 9%. So you add that up, it's coming up to about 45% or more of initial denial. So the interesting thing about this, and I'm going to give coders their due, which they deserve, again, incredibly hard job, is we had found when we dove into these denials and really teased it out, because information needed tells you nothing. It's a payer's way of being very vague and maybe even a little tricky. So you don't understand what's the real reason for this. But when we drill down to root cause and work with our auditors and coders, what we found was things were coded perfectly. What was in the medical record was represented perfectly on the claim. But the payer policies had been shifting so much that things were kind of didn't matter that the claims were coded so effectively. I'm going to give you an example of some of the bigger ticket things we saw. or more interesting rather. So a lot of denials. I'm going to give an example. Process of cardiac resynchronization with an implantable device. We had found that these claims were coded accurately with the highest levels of integrity, but when it got to certain payers said, yeah, this is coded right, but we will only pay for that cardiac resynchronization with an implantable device if you submit documentation along with the claim to tell us why you didn't go with a more traditional therapy as opposed to an implantable device. So that's one that I thought was really interesting. Another one was we had coders that were coding and auditors that were auditing for a lot of implants. Another one that I have here is pacemakers, sending out pacemakers to a certain payer. And the payer said, yeah, everything on this claim is perfect. You coded it perfectly. But according to our policy, when you send a pacemaker that's made by a certain manufacturer, it got that granular. I think it was Medtronic. You have to also code a clinical trial number on a certain loop and segment of the claim and make sure that's reflected in the documentation and so on and so on. So where I'm going with this is I really want you folks after this to dive into your information needed medical necessity type of denials, because there's a treasure trove of insights in there that if you drill down and really look at the root cause, you'll be able to also train your coder population and yourselves to say, okay, or create edits in a system that says, when I'm going to send out cardiac resynchronizations, or I'm going to send out these pacemakers, I now know that I'm coding it correctly, but certain documentation has to be sent along with it. And we're going to talk more about, as I said, coders being deployed not only to code high-risk DRGs and HCCs, but being kind of double deployed by understanding payer policy. So really what I wanted you to take from that was really understanding the root cause of those coding related denials, because it's not always a situation as simple as being up-coded or down-coded or not coded correctly. It's coded perfectly, but there's a lot more to what the payer wants. And it's very hard. We understand it's incredibly hard to keep up with all of those changing policies. Last thing we're going to talk about before we get into suggestions and best practices and all of that is payers. They are heavily investing in AI and machine learning and ways to really identify anomalies. And this is how they're bumping your claims up and your coded claims up against all of this fancy technology to really put you at a level of scrutiny that we have never seen before. And the second bullet kind of explains what we're seeing in our MDaudit community, which is external payer audits from RAC, MAC, TPE, even your simple CBRs. They've gone up exponentially 4 times than what we saw in 2022. And a lot of our customers are also reporting that within those ADRs, those documentation requests, demand letters, whatever you want to call them, the number of accounts being scrutinized and the pages in those were through the roof. So that's where we're going to end with, what does the current landscape look like from a payer perspective? They're doubling down in their denials. They're really sending out a lot of these external audits. We need to make sure that mid-revenue cycle is solid, that we're aware of those payer activities and what they're doing, and that we're putting coders and auditors in the best circumstances to make them successful. Because in that mid-revenue cycle, auditors and coders have a real tough job and an incredibly important job to make margins healthier. So we're going to get into best practices in the next slide, but I wanted to relate it back to something that, and I want all of you to think about this as well, is where did we see increases just in audits? And these are internal audits within our community. So we saw a 50% increase in risk-based audits on the pro-fee side, facility inpatient, facility outpatient. Really what it means, and I don't want to get too much into it because we're going to talk about it later, is we can't just rely on auditing our physicians and our coders once a year with a sample size of 10. we're not going to really be able to unearth some of the things that are causing coding related denials in that revenue leakage. So we gotta move to a more risk-based approach. If you take anything away from today's presentation is that 170% increase in HCC audits. Gotta make sure that you're looking at HCCs, particularly when they're billed to Medicare Advantage plans. They're being heavily scrutinized. Want to make sure that there's coders that have special certification in risk-based coding and value-based reimbursement. I'm going to move over to DRG audits. A lot of the DRG audits you're familiar with, high-risk DRG, sepsis with vents over 96 hours. We'll talk more about that. But the 10% is an increase in pre-bill audits. So along with taking a risk-based approach of auditing coders and coding activity, got to do that, got to get more on a pre-bill basis. Retrospective is great, but got to move to a pre-bill process so things are being caught before they are sent to the payer. Because as we talked about, if it gets to the payer, they're taking forever to adjudicate and doubling down on denial. So if you can have those important conversations between auditor and coder on a pre-bill basis, there'll be significant improvement to first pass pay rates. All right, so we're getting into some best practices. Some of you are going to be very familiar with some of these. Some of you are employing these right now. Some of them are going to be new to you. So this is where we want you to, some of the nuggets you can take away. And again, this is coming from our community of auditors and coders that work very successfully together, but are still fighting an uphill battle because of payer scrutiny. So the first thing we're going to talk about, we're not going to boil the ocean on how this all gets done, but some of the suggestions and things we see happening is a blend of retrospective and prospective audits. So again, not easy to do. Technology can help with this. We're not here today to talk about technology or sell you technology, but got to start moving to a more prospective approach. It's okay to be doing retrospective audits. They have a lot of great insights. But all of your technology that you're working with now, your EMRs, there is options to put pre-bill charges in a hold mechanism. Some of you have Epic work queues, other reviews with other systems, Epic, Cerner, Allscripts, whatever it may be, Meditech. There are ways to put these charges in a work queue and not have them released until you can kind of have some dialogue between auditor and coder on what is the highest levels of accuracy and integrity. So number 1 and 2, number 2 is rebuttal process. They work together. So not only do you want to start doing some pre-bill audits of coding quality, but you also want to make sure that along with that process, you're able to allow those coders to have a review and rebuttal. So I know a lot of you are managing a lot of this on spreadsheets and manually. Whatever works for you is great. Again, technology can really help with this and streamlining that, but you need a process that not only can you as the auditor look at what was coded by the coder, but then say, look, I think for this diagnosis code, this is more accurate, but I want to send that to the coder for them to do a review and rebuttal. Coder can get that, do their review and rebuttal and send it back. All on a pre-bill basis to ensure that it's going out correctly the first time. So not down on retrospective audits, but figure out what the healthy blend is at your organization. And that is going to take some change management. I have that up there because, we need to work with our compadres and colleagues in revenue cycle and revenue integrity to say, what is acceptable to you and to the organization and holding up certain charges for that pre-bill review. Doesn't mean it has to be more than 24 hours or 48 hours. It could be certain high-risk things, high-risk DRGs, HCCs, CCs, and MCCs. Be smart about what is held up. And that's more of an organizational discussion. But got to have got to start moving towards prospective audits and have a full rebuttal process built in to engender those dialogues. I have here employee analytics. That's a big statement because analytics can mean a lot. But what we mean by that is don't just dive in and not know where to start. So with a risk-based approach, it's where you could even say, okay, well, I'm going to give an example. I'm going to take my PEPA report. A lot of times we're not looking, our PEPA reports kind of can fall in the background. We're busy with other things, but think about it. You can look at some of those high risk measures on your PEPA report. I'm going to take one, DRGs with CCs and MCCs. Technology can really help you see, and you can do it through as well, looking at your claims data and say, for DRGs with CCs and MCCs, where do, compared to others that are submitting data to CMS, where do I look like I'm over or underutilizing those? If it looks like you're overutilizing them, then that may be some upcoding. If you're underutilizing them, maybe you're undercoding. I know that that's a simplistic approach, but start with the PEPA report. And you can say, okay, for this populace of claims, my DRGs with CCs and MCCs, you could even look at it. A lot of folks are saying over a 24-month period, I've been doing that DRGs with CCs and MCCs out of a certain facility or a certain specialty 20% of the time. But over the last 12 months, I've seen that go up to 35% of the time. That's a spike that you want to say, why is this happening? Is it a coding issue? Is it a documentation issue? Am I upcoding? Whatever. You can start there and then back that into the claims that were coded, who coded them, and kind of start with things that are more of a high risk. Things like PEPA report again, and I keep on mentioning particularly HCCs, CCs, and MCCs. Those things are be highly scrutinized. You can really kind of start with those. Can't take the traditional approach, just isn't feasible. We talked about that before. With limited staff, it's not always easy to go and look at 1,000 coders or even 100 coders with a sample size of 10 things that they coded. It's got to take more of a risk-based approach. There's a lot of benchmarking and other statistics and stuff out there available that, again, technology can help you understand. Here's where my highest risk areas are by interrogating that billing that's going out the door. So under employee analytics, there's something called use denials for root cause. This was something that I really needed to wrap my brain around. So in my years of working with coders and auditors and kind of looking where there was breakage along the entire revenue cycle continuum, I always kind of left the denials piece to the back end kind of revenue cycle subject matter experts. But what we were realizing, and what I've seen in 6 years now, 6+ years at MDaudit, is taking a blend of not only looking at analytics in your claims data, but in your denials data as well. And I'm going to talk more about the auditor side of the world here, is sometimes I find our auditors are too focused on the claims data to then say, I need to have a discussion with coder Jane Smith or coder Dana Finnegan. Looking at the denials is almost the real source of truth. It's cutting to the chase. So if you're able to have technology and other methods to go into those medical necessity denials, those bundling denials, those non-covered charges denials, particularly the ones that would say, other ones that say information needed, like we talked about, and be able to drill down to what payer is that denied me? What policy are they talking about? Let me access that policy. And then even drill down and say, what attending provider was on this case? Who codes for that attending provider? Who codes for that specialty of orthopedics that that are doing those implants that we talked about? That's a really great understanding to be able to go in and say, okay, I see this large surplus of denials in my implantable devices. It's either A, just simply against payer policy, they're not going to pay for it no matter what we do, or, that has traditionally been coded by Jane Smith. We want to introduce her in that department to the payer policies, how this can be coded, what's acceptable for diagnosis codes, and what's the documentation that needs to be sent to support something that they traditionally don't pay. But if we do the right things in terms of coding and documentation, we're going to be in a much better place. So point being, you may be doing this now, but I found a large part of the community has just started to come around and say, risk-based audits for coding quality and coder audits, not only claims, but remit data, denials data is incredibly key to look at. I've mentioned coder deployment a few times here. Not always easy to do, I understand, because it's very limited staff, hard to find the staff to be doing such a tough job on a daily basis. But seriously consider having coders code by specialty and payer mix. So traditionally, we had seen a lot of coders that were coding on the, whether it's inpatient side or outpatient side or pro fee or certain specialties. That's great. That should always be. But when we saw coders and auditors too that were specifically exposed and became almost subject matter experts in certain payers, doesn't mean you have to know every one of your payers in your payer mix, but one or two of your commercials. We saw that when they were very much engrossed in those payer policies, there was significant decreases in denials for the things we talked about, like information needed, and payer deems information submitted does not support this level of service. Again, those are the denials they're sending out to make us scratch our head. But when coders were coding and understood the policies, the documentation that may be required on that first submission and other things, huge increases in first pass pay rates. So again, it could be a coder that's coding on the inpatient side, but is specifically also assigned to, Blue Cross and, Cigna. You decide. It's an organizational and operational and strategic discussion, but it has huge benefits. I'm going to talk about a weighting and scoring methodology. This is a little bit, I know it's a little bit in the weeds, but what we found was there was in our community, in our community does a great job, but we had seen that it's very important to have a consistent weighting and scoring methodology and naming conventions, meaning when you're an auditor and you're auditing coding quality or coders, whether you do it by specialty or acuity, whatever it may be, you want to make sure that when there's a diagnosis disagreement or something like that, a change in a DRG, that the actual weighting and scoring that you apply to that is going to be the same for each coder or for each coder group. Because then when you're done doing these audits, you can have a nice vantage point of accuracy rates. And if you're applying the same weighting and scoring methodology, you're very able to see who your high performers are and some of the ones that maybe are not coding to the highest levels of accuracy and integrity. And when I talk about naming conventions, I mean, a lot of folks will aggregate a lot of data over a year of auditing coders and coding quality, but the naming conventions have changed a lot. So you could have a million different reasons why you're disagreeing for diagnoses, and you can't really get a good specific number. So you want to make sure, again, not only is the weighting and scoring consistent, but the naming conventions you're using across auditors and across coders are the same. Because when you aggregate all of that data, it's very easy for me to go into our community and see sepsis-related DRGs with events over 96 hours are always being denied. And here's who's coding them. And here's who's auditing them. You want to be able to have that type of data at your fingertips, and that can only be done if you have a consistent methodology. Going to talk a little bit about some stuff here too. Subsequent audits. So, and I keep on saying this, technology can help you with this, but if you clearly define a weighting and scoring methodology and naming conventions and all of that, it's very easy to then assign outcomes to that. I'm going to give an example. Okay, if I take a sample size of 10 of my coders' claims, and based on the weighting and scoring methodology, they achieve a 90% accuracy rate. Then you've done the methodology, but the next step to that is to have another scheduled audit methodology. So if they hit that 90%, then you're going to audit them 1 year later. If they don't meet that 90%, then it will be, say, 3 months later or 3 weeks, whatever you operationally decide. I'm seeing best practice, again, is 1 year later for passing, failing 3 months later. This includes education in the meantime, but you want to not only clearly define the scoring, the weighting, the outcomes, pass, fail, but based on those outcomes, when will the subsequent audit be? A lot of that falls through the cracks. If we're trying to manage it on sticky notes or Outlook, you want to have a really technological, streamlined way to make sure that you're getting and executing on these subsequent audits. The next one, it's really self-explanatory, but I would have been negligent not to leave it out, because when I look at statistics, I have a tendency to do this, is let's not confuse productivity with integrity. So it's very easy for me to go and say, wow, that person coded, 100 cases, and just think, wow, they're really banging it out. That can be used as some sort of risk-based approach as well. It's looking at, how many cases is a coder getting through. If it looks like it's same as for your physicians. Think about it as a physician. If you see a physician that's cranking out, 40 office visits a day, it's going to send up a red flag, or if work RVUs seem through the roof. Again, don't confuse productivity with integrity. It's really an excellent way when you're looking at productivity to identify those that may be doing a smaller volume of coding, but are doing, very acute patients on the inpatient side with a lot of multiple comorbidities. We would expect them to not be coding as highly or as many cases as someone that may be just assigned to the E&M side. Again, it's a 101 type of thought process, but a lot of us that have been in the industry for a long time can sometimes have that confusion. So this one is incredibly important. The next one is close the loop. So I mention this because we know that you're very much understaffed, and sometimes the education piece unfortunately has to fall through the wayside. You may have a great report that you want to share with your coders to have that corrective action dialogue and education session, but you're just really quick. You get in your email and you send it off and say, you passed, you failed, this is what it looks like. Post-audit, really always have to break out some time for that education conversation. When we talk to coders, just through my experience, they like that one-on-one education. It proves to be highly effective, as opposed to coming in and saying, okay, we're going to sit down with a bunch of coders, or we're going to sit down with coders that are coding for orthopedics. Understood, it's hard to get this all done with lack of FTEs, but that one-to-one is incredibly effective. And there should always be a technology or a process where you, the auditor, and again, I'm going to go back and say sample size of 10 claims, where you're able to have a report that spits out to you that says, here are the claims I looked at. Here's what the claim looked like before, what it was coded as by the coder. Here are the changes I made. I changed a DRG, or I added a diagnosis, or I removed a diagnosis because it wasn't supported by the documentation. I added a modifier, whatever it may be. Claim before, what you did, and then comment and commentary and audit findings as to why you did that. Because at the end of the day, if you have a very limited bandwidth and time, you need to be able to not go through the entirety of everything that you audited, but really where you made the most changes, and explain that with the coder, and have that one-on-one. Again, that education is proven to be highly effective in when those subsequent audits that are done that we talked about, we're seeing accuracy rates go up quite high, when two things are happening: rebuttal that we talked about before, have that healthy rebuttal between auditor and coder, and education, not always easy to employ and do, but when those two things are done in conjunction with prospective auditing, a lot of those coding related kind of scary statistics we saw before will be incredibly mitigated. Fee for service versus value-based reimbursement. So we're all cognizant of what's going on with this. I think what I would say about it is having a special unit or task force to look at those HCCs. Again, especially the ones being submitted to Medicare Advantage plans, CCs, MCCs, all that stuff we talked about. You can see that added to a prospective flow. One of the things that we all know about now is we're seeing that, you have CRCs now, certified risk adjustment coders, that are very specifically deployed to these claims, those that will be subject to that value-based reimbursement. So just again, I've been saying a lot here in terms of have coders deployed to certain chart types, inpatient, outpatient, pro fee, or specialties, whatever it may be. Also, try to have them engrossed in payer policy. And again, a third thing here is because of the shifting reimbursement methodologies and patient care methodologies, a good place to also have someone that has that specialization. Now, again, it's asking a lot, but some of those coders that you have gleaned through your statistics and data as high performers, not only high rates of accuracy and integrity, but solid productivity. Those are the ones that if you can identify them through the data, they have the abilities to be deployed in these multiple places to really kind of be your leaders in those areas. I have here coder technology. So I'm talking about, I've just listed CAC, but I'm talking about, CAC, AI, all of this stuff that coders have as tools. What I would say is it's a great thing for the industry. Coders need help. Things are constantly changing, but we don't want to, when we're not a coder, sometimes we forget how hard that job is, and we think, oh, well, they're using all these tools. The output is going to be perfect or close to perfect. Always have that gut check of both auditors and coders, particularly coders, looking at what is being produced by things like CAC. CAC, like I said, very high accuracy rates, but there are, as you know, a lot of false positives. And no technology ever works without the person aspect. I think we're all aware of that, but sometimes when we're trying to rush to meet filing deadlines in high volume and lack of FTEs, we may not spend enough time. We don't spend enough time looking at what those coder technologies are spitting out. Below that, talking about plans for the future. I've been in a lot of meetings across the country at different HFMA, HCCA, NARI, and there's a lot of folks in the mid-rev cycle that are really excited about autonomous coding. What I've heard is that, maybe taking a 60-40 approach to start off, which is 60% always in the hands of the coder because they're truly the specialists. Maybe 40% is done with like ED and E&M. Not to say that that's easy, but it's easier than your inpatient lengths of stay and all of that, where some of that autonomous coding can be put towards that 40%. What I'm saying there is I think we should all be excited about this, but just like the CAC, be aware of the limitations. And two things that you have to do when you're planning for this is have auditors and coders on board with it. Don't be afraid. of the technology. It's out there, it's going to happen. But as I said, with the CAC and other things, always has to have a people-centric approach. If you're ever getting people coming to you with a technology saying auditors and coders are not an integral part of it for it to work successfully, then you don't want to be talking to that vendor. And the other piece of it is change management is going to be critical. Meaning whether it's auditors, coders, and others in the revenue cycle continuum, it's exciting, but it's a little scary too. So you want to do your due diligence in bringing in the right stakeholders along the continuum to make sure that these types of technologies, particularly the autonomous coding, are implemented appropriately and have the people centric approach, so people are always part of the process of what is being coded autonomously. We're almost getting to the end, 12:51, so appreciate you sticking with us. Got a few other things here. I'm going to skip a couple of these, and I'm going to say don't silo coders. I know I came from an organization in my past where revenue cycle folks and auditors and everybody else were kind of in one section of the building, and the coders were in another section, heads down, doing an incredibly hard job, and there were silos there. And that was bad. So always include them in the big picture. So we talked about some of this before. Coders should always be involved with the dissemination of payer policy changes. So a lot of that always goes between rev cycle and rev integrity, and coders are kind of left out sometimes. They should be included in monthly meetings and in disseminations of payer policies, big changes that are taking place. What are the top denial trends at your organization? Make sure that ones that fall under a coder purview, like medical necessity and non-covered and diagnoses are not covered, and that is something that they're seeing. You're not just bringing it to them when there's a big issue or a backlog of this type of denial. Always keep them in the loop. We have seen, this was something that I thought was really interesting, is we've had a couple of organizations that have a coder specialist or a coder on their payer relations team. Meaning, when you go into these negotiations with your payers to say, this is, where we feel you're wrongly denying us, or where you're not paying according to policy, when you have coders in that room, there's a lot less hijinks kind of going on. I'm not pointing a finger at a payer, but those coders can really keep people in that room very, very honest, and can call them and say, look, Mr. Blue Cross Blue Shield, I can see based on your policy that you're asking for this. This is what we're submitting. This is how we're doing it. It's incredibly important to have them in those discussions. Don't just have them code claims and then not be part of the process. All of that rebuttal, making them aware of payer policy changes, denial trends, having them involved in these type of discussions with payers, it really brings incredible fruits to your organization. Another thing when I talk about involving coders, auditors and coders together, is external audits. So we talked about the rise in external audits, particularly RAC, MAC, TPE. After the pandemic ended, they really ramped things up. I have seen when organizations get those demand letters, send back the documentation, do all of that, when they have involved coders in that process and not just made strategic decisions about, okay, this is a $100,000 claim, this is a $1,000 claim, we're just going to throw our efforts against those high dollar claims. When you involve coders in that and say, these are some of the accounts that are being scrutinized, and send those to coders for an internal review, that has significantly increased dollars retained. And refunds are going, and it looks like I have that backwards, but I will change that before I send it to you. But when coders are involved in the external audit process, and they're able to do a gut check, of what that demand letter is essentially saying, we're going to take back money, they are able to come in and do an internal review and significantly increase dollars retained. Have them part of those processes as well. I think what I want to do now, and I'm going to leave with this, and then we're going to go into some questions, but trust technology, but be picky, particularly in a vendor that's going to put the auditor and coder into these dialogues and processes that we talked about that are so important to margins. There's a lot of folks out there that are talking about 100% coding scrubbing. Let's talk about, forget about autonomous coding and CAC. Those vendors that are just saying, hey, I'm going to look at everything that you've coded and scrub it. And I'm going to tell you where something needs a modifier or where this should be a different DRG or whatever. That is, I think, pie in the sky. Nothing can be 100% coding scrubbing, meaning anything that's kicked out by those scrubbing engines or predictive engines or AI, all this fancy stuff you're hearing about, needs a person in the back end to validate those findings. Doesn't have to be all of it, but always keep people involved in the loop. Auditors and coders and others, it's a partnership with technology. So folks, what I want to do now, because we're at about 4 minutes left, is go into a Q&A section. I know we've gotten a lot of questions. I've seen them popping up, but I'm going to turn it over to Joy now just to ask maybe some of the first few ones that were submitted.
Great. Thank you, Dana. So I will actually, looking at the time, I'm going to launch our closing poll as Dana's answering questions so that people, if you do need to jump right at one, you're able to give us your feedback and also listen to Dana's responses. Okay. So actually, Dana, we had a few questions when you were on slide 11. So I don't know if you want to go back to that slide to show it as answering them, and they're all pretty similar. The first one is, are these denial rates due to registration coding or both? Due to registration coding or both, all types?
Can you say that one more time, Joy? Sorry.
Yep. Are these denial rates due to registration, coding, or both, all types?
The denial rates that we were looking at in most of the sections were specifically related to coding. So there was some there that had eligibility and registration. Those were more where payers were kind of parsing things out a little bit more, but the statistics we talked about largely were related to just coding, medical necessity. And when we looked into things like information needed, documentation needed, specifically related back to coding.
Okay, great. And then on the same lines of that question is, are those line denials or full claim denials?
Those are line related denials, meaning, we know that, on a claim, you can have 5 or 6 different reasons for denial. But we haven't aggregated it at the top. It's by individual line item where we're seeing those coding and medical necessity, et cetera, related denials. Okay,
thank you. And what about implementing more robust claim scrubber applications to identify cases for a pre-bill analysis?
Yeah, I think many of you in our organization, our community, and others that are not, you have fantastic claim scrubbing technology. What I have found in my kind of background and when we've looked into our actual community scrubbers is they do good things, claim validation, maybe more simplistic coding scenarios. But those claim scrubbers, although very valuable, missing patient demographics, this and that, they're not catching high dollar, high impact denials that are related to payer policy. They just don't have the sophistication. So that's where it's a great thing. It'll clear up a lot of denial issues and help first pass pay rates, but you still need to employ a lot of what we talked about to catch that more niche stuff that's denying for medical necessity due to payer policy.
Great, thank you. Okay, this one just came in. When you say coding, clinical coding or true coding? For example, clinical coding is where the provider documented sepsis and it was coded as such, but the documentation according to the payer doesn't support sepsis with the appropriate clinical indicators.
Yeah, I think our examples are not so much when we've looked at our data, we're not going in and looking at any type of documentation deficiencies or anything like that. We're talking, true coding denials where claim will go to payer. Payer will either say, after looking at the documentation, we wouldn't have coded it this way, or these codes that you submitted are not payable via our payer policy for these many different reasons. So I think it goes back to, we know you're coding, a lot of coders doing a great job, but we need you to be, all of us to be a little bit more aware of what's denying at the payer. That's not so much CDI related.
Okay, thank you. And I'll ask one more. And those questions that we did not answer, we will follow up after the webinar. Someone will be in touch with you to make sure we cover all your questions. And the final one is, if a payer, example UHC, relies on AI coding and no clinical reviewer for denials, how would you approach for the payer to re-review?
So that's something that we're experiencing a lot, is payers just running their AI over claims and denying at historically high rates. I think you have to take a kind of a pragmatic approach to it. Again, a lot of that stuff that you'll see in our statistics, if you look at your own data, is the things essentially that are high risk when you're submitting to UHC or other payers. Those are the things that you want to start doing a more prospective review of before it goes out the door if you can, or carrying statistics about what they are denying, seeing if it's correctly denied compared to their payer policies. That's where you need to start then involving auditors and coders in those payer relation discussions, because we know they're just going to deny things ad nauseum and back it by saying it's our payer policy. That's where you need to understand that payer policy, see the best ways to code those claims, as well as attach the appropriate documentation. So that's a game a lot of payers are playing, the AI and denying in mass. You just have to kind of start chipping away at that iceberg and start with your highest risk coding, not your E&M stuff, but really the stuff on the inpatient side and the outpatient side as well, because as I said, that's where a lot of services are shifting.
Thanks, Dana. And with that, would you like to move forward with your short demo? And
yeah, sure. So folks, for those of you that want to stay, we are going to do just a short demonstration on our platform. It is literally going to be, I think, under 5 minutes. And what I'm doing right now is I'm just pulling up how our system can engender some auditing and dialogue between auditor and coder. So again, this will only take a few minutes. What I'm going to do is jump into a claim right now. There is absolutely no PHI on this, all de-identified data. So I want to say that right off the bat. But what I want you to see, and this is an inpatient claim that has, everything that's built on an inpatient claim, like diagnosis codes and DRGs and everything at the revenue code line level, admit type, admit source, all of this stuff, everything that goes out on an inpatient claim. But what our system is able to do is also match up not only what went out on the claim, and this could be done on a pre-bill basis, this could be done on a post-bill basis, but we are able to also show you who coded it. We have the technological underpinnings to match up your claims with who coded them. Now, what I want to do as an auditor is very quickly go in and say, hey, this is what I agree with. And this is just an example. I agree with the first few diagnosis codes that were coded by the coder. But you know what? I'm going to go in and I'm going to just make a change here. I'm going to edit that diagnosis code. And what it will do is bring me to what was coded by the coder, the Z87.891. I'm going to go in as an auditor and put what I feel that should be. And I'm going to go and just say 11. So again, we can show you what the coder coded. You can put in a supported value based on your review of the documentation. I can then go and put we talked about this naming convention, why you're disagreeing. I'm going to say diagnosis disagreement, and you can see it weights at a 0.25. I can even say, that might be a potential overpayment. It weights a little bit more. So you want to remember to have great naming conventions, great weighting and scoring, and then an ability to go in and say, hey, coder, this is why I made this change. Can you please review it? And I'm going to save that. And then you're going to see when I am done doing a review, and I can review anything I want, and I say, hey, this is completed, I can send this right to the coder for review. I want that to happen. And when I save and close it, system will send that directly to the coder so they can do a review and rebuttal of that. I'm not going to show you what the coder sees, but what I'm going to show you in this screen right now is what you can get back when you have a platform that can engender these dialogues. So I'm going into this claim. You can see it was coded by the same coder. But anywhere in red is where I've made a change. I changed this diagnosis code that was originally coded. I also changed this DRG. But if I want to go in and see dialogue, I can again see, hey, this is what was originally coded in 872. Sepsis without a mechanical vent. But as the auditor, I went in and changed it to 870. I saw that there was a mechanical vent. And I said, hey, that's a potential underpayment. And then I told my coder, hi, can you please take a look? When I added it up, 98 hours. Coder came back and said, you know what? I still don't agree because I am seeing something else. Now, at this point, you as the auditor can respond back. Or you can say, thank you very much. Didn't see that. This is a way a platform can truly engender dialogue between you and a coder, auditor and coder real time, so things can go out the first time correctly. Again, this can be done pre-bill, it can be done post-bill, but we want you to know that it don't always have to rely on spreadsheets and sticky notes. Technology can really help you accomplish a lot of the stuff that we just talked about. So that, folks, for you that stayed around, was just a really quick way of showing you that type of dialogue that can be engendered when you use the right platform. So folks, we really appreciate your time today.